Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So today I'm talking to Dr. Liam West. So Liam's a sports and exercise physician based in Melbourne, Australia, and a fellow of the Australasian College of Sport and Exercise Physicians. Liam's currently the head doctor for the Hawthorn Football Club. That's Australian rules football, based here in Melbourne. And he consults at Alphington Sports Medicine Clinic, also here in Melbourne. Liam has a sports science degree and a medical degree from Cardiff University in Wales in the UK, and a master's degree in sports and exercise medicine. So you may know Liam already. He's been quite prolific in his knowledge translation work, with most notably with the British Journal of Sports Medicine, which includes writing blogs, hosting podcasts, and publishing his own research. He's currently a senior associate editor for the British Journal of Sports Medicine, and he's authored a number of publications in peer-reviewed journals. If you use the Bruckner and Kahn Clinical Sports Medicine textbook, which I hope you do, Liam's a chapter author in that textbook, and he's worked with a number of high-profile sports clubs all around the world, but particularly in Melbourne, Australia. And that's probably just the tip of the iceberg in terms of the work Liam's done and has been involved with in his career so far. And in this episode, we dived into Liam's background and his training, which are the foundations of him as a health professional, which is one of the themes of this podcast, the foundations of individuals and experts and where they came from. And then we took an even deeper dive into how Liam practices as a sports doctor, including the practical aspects of how physiotherapists can work alongside sports doctors, how you can communicate with sports doctors, what sports doctors really want to know in your referral letter and your updates to them, and some questions I really wanted to know, such as how he would manage some common conditions and where a sports doctor should be involved in patient care. And then what I really enjoyed was we focused specifically on the person instead of the patient. We had quite a deep dive into Liam's approach regarding integrating the biopsychosocial elements of patient care and the practicalities of how he does that, the types of questions he asks, and how he brings the person in their own healthcare journey. It's a very contemporary approach and really useful, really good to listen to. And when I say we here, I mean Zuzana and I. If you're new to the podcast, Zuzana, my wife, sports physiotherapist herself, now a PhD. Zuzana's finished her PhD looking at hip and groin pain and the lateral hip muscles. And she can tell you all about that in an upcoming episode and her PhD findings. But Zuzana was able to join me for the last part of this conversation. And she dropped into the home studio where we do most of the recording of the episodes. And she added her own insightful comments and commentary on the topics. So that was really good. And I'm talking here in the past tense because I recorded a version of the introduction you've just listened to about Liam, and there was a problem with the audio. It went quite distorted and difficult to listen to. So rather than putting you through that for the first minute or two, I re-recorded the introduction. And what I'll do here is I'll lead you back into the place where the audio came good again, mercifully, and where I introduced Liam. And what I said in that recording was, Dr. Liam West, welcome to Physio Foundations.
Luke, thank you very much for having me. It's an absolute pleasure. It's actually a really interesting area trying to get people engaged and started on their journey. And it's actually something I've got a passion for. So I'm really thankful for being here.
Fantastic. Now, it's good to have you here. So what have I missed in the introduction? Anything else that you'd add there that's sort of tell people about your background and interests in training?
Well, number one for me is I'm a father. So I'd like to talk about my family first. So I was talking to you just offline there. I've got 2 kids, 2 young boys. And that's certainly given me a lot of challenges, but balance probably to work, and something people should consider. My lovely wife, Amelia, who I met here in Australia. And obviously my family are back home in the UK. So I'm a POM. I've come across and taken your jobs. So that'll be the first thing. I've moved across, and I've actually moved across for my career, really. I actually told my mum and dad I was going for a year. I was just traveling. I'll do, work in the hospital, see what happens. I'll come back. And, Yeah, that was in 2015, so they're still sort of waiting.
Right.
Which is, anyway, I'm not sure they've forgiven me yet, but we might get there. But my background, look, do you know what? I actually think physio would have been my perfect career. And I look at some of the physios and I do get jealous and things like that. But ultimately, I grew up, my dad was a farmer. My mum was a teacher at school. We didn't have anyone in healthcare, not medicine or any type of healthcare in our family at all. Actually, the first person ever to go to university in my whole family was my older brother. So I was like, oh, crap, I better do something. So talking to my careers people and things like that, school as you do, I really like science. I love learning about the human body. I was okay at sport. I quite enjoyed it. I sort of thought, can I combine those? And I never knew about sports med, so that didn't actually happen. And that's where I was thinking about physio. And ultimately, my careers advisor was like, well, why don't you think about medicine and sit these tests? And I sort of fell into medical school. The only other component would have been one of my girlfriends, in case my wife listens to this. At the time, her dad was an orthopedic surgeon, and so took me under his wing. And I actually went into med school thinking I wanted to be an orthopedic surgeon, and then I met a lot of them, and I thought, this is not for me. I actually like people. And so I fall into Cardiff Medical School, and you've talked a bit about this in your intro, so I'll just give the chronology for the listeners. So going to med school, that was, I think probably 2007. I have a feeling some of your listeners might not have even been born, but 2007. And I bumble along the whole turn up at lectures with one meal a day, a lot of servings of alcohol, you're hungover, what's going on in life, I'm living away from home, didn't really switch on until my sort of second and third year. And that's where it's actually very strange. I actually hit up the dean of med school, which I do not advise doing, and was like, you're not doing enough for me. I want to have this career and combining my passion for sport and medicine, and there's nothing about it in our curriculum. And then I remember after thinking, what have I just done? But ultimately, it was a good spell, and that was my first step in. He introduced me to a renal doctor, a renal physician, and so a nephrologist who was actually the head doctor of the Welsh rugby team. So you don't put those two things together very often. But I ended up we created student-selected components. So I created a module in sports medicine myself because it didn't exist. I went on camp with the Welsh rugby team, and then from there it just snowballed. I was very lucky. It was an opportunity where no one else was really getting into it at a student level. And therefore, I was on camp with the Welsh football team, and I got to go to the national golf, all these sort of things that I set up. But anyway, I do that. I decide, as you mentioned there, a sport and exercise science degree, because in medicine you have this thing called intercalating in the UK rather than dual degrees. It's an intercalation. So I paused medicine after 3 years when I did a sort of crammed in a 3-year degree in sports science in a year. Went up to Bangor. It was a very interesting place, and then came back, and I had to finish off 2 more years of medicine. And in that time point, I basically thought, right, there's nothing going on. I've got a lot of energy and I've got to put it to some use. And created a society at my medical school called CSEMS, Cardiff School of Exercise Medicine Society, and Student Exercise Medicine Society. And that's still going. That's probably one of my proudest things. It's still going. It still runs national conferences. And I actually ran a national conference on my own, which was stupid. In my 4th year, we had 250 delegates come. It cost in Aussie dollars, it cost $20 to come, with all these things. It nearly killed me. But ultimately, I then set up the UK Society and then a European Society. It was all aimed at getting student doctors and physios involved in sports med, getting them opportunities, mentorship, linking them with professional people, providing lectures. Ultimately, I ended up helping write the new curriculum at our med school, et cetera, et cetera, et cetera. Through all of that, I then got involved with BDSM. And ultimately, one of the tips there is if you put yourself out there and you put a bit of energy, you'll be so many doors open up. But you just got to take that first step. And so BDSM, that was interesting. I did some blogs. Then I started to do the podcast. And then from there, I became one of the first, I was the first, what's called BDSM Kid. You might have ever seen a hashtag for it. I was getting flown to conferences in different countries. It was very fun, especially because I didn't have a lot of money. It was pretty good. And then I did an elective. I came out here in 2013 to, as you call it, Melbourne. Actually interesting, when I first came, obviously it's geese, right? So I was calling it Geelong, and everyone looked at me like I was broken. But obviously Geelong now, and I've got it, and we hate the cats because I'm part of the Hawks. But I come over here in my elective, finished being a doctor, then decided, well, I love education apparently. So I started a master's alongside becoming a full-time doctor, which actually took me 5 years with sports med. So those are sort of my degrees. And then I'm out here, I had to, because the Aussies, you guys make, I'm an Aussie now, so I can say this, but you make it so hard for people that aren't Aussie. So I had to get a permanent residency before I was allowed to even apply, and to do that's all the money. So it took me a bit of time. I worked at the Trobe, I worked at the Mighty Uni Blues with your boss, Zuzana, and ultimately got onto the path, the Australian College of Sports Exercise Physicians Fellowship Training, and that took me, I did it in the shortest time of 4 years, and then a couple of years ago, came out of that, and then I had, as you mentioned, a lot of jobs along the way. So that's a very long, that was meant to be short, background of me and training. In terms of my interests, they change along the years, as I'm sure you tell to your students, which I was so career focused, like hopefully you can see all that. The Hawks laughed because my CV that I put in, I tried to shorten, was 18 pages for my interview when I went for head doctor previously a couple of years ago. And I left medical school and I'd been to 50 national or international conferences and done all these different things. I used to go on a thing called a megabus because I didn't have any money, so it's £4, $8 to go from Cardiff to London. It would take 3 hours. Go and I'd meet someone for like literally half an hour, a coffee, because we didn't have Zoom. No one did stuff over Zoom or telehealth, things like that then. And then I'd come back, I'd be back at 2 a.m. and then in the hospital the next day. I just because I loved it. I loved the idea of sports med and all those sort of things. And so when you do things like that and you put yourself out like that, and this is, I mentor people when we talk about these things, you end up padding out a CV. So it's not like I'm great thing. It's just I've had an amazing journey. That's the way I look at that. So my interests realistically now are trying to become the father I'd like to be while still being a good husband, and that's hard enough. And then trying to be, good in my career, which spans varying roles from elite sport, clinic to some surgical assistant.
They're good goals, and you've got them in the right order. So so it's interesting that your background there, because I like to spend a bit of time on the background, because I believe a lot of the listeners are either planning careers or reflecting on careers, and they've told me so, and they need to know a little bit about why you've done all these things. And so you really created a lot of those opportunities because it just didn't exist. And you've got a lot of energy, as you said, and you wanted sports medicine training locally, and so it didn't exist, and you set it up. So that does make sense why how you've been so active in the Australian scene as well, and setting up a lot of professional development and training for other health professionals. What made you? Let's go back to the start of that. You're jealous of physios? They might be jealous of you. What is it? So, and maybe the physio could have been the perfect career for you. Tell us more about that to the physios listening.
Yeah, well, look, I think to me, and I looked at physios more so with that statement in elite sport, probably because that was my experiences during med school. I didn't see many physios in clinic. I learned way more from physios when I was a student and probably beyond than I did doctors. Doctors, we're all egotistical, we love ourselves, and then maybe we weren't opening for a bit. But so I spent a lot more time around physios, and I felt like their interactions with patients were closer. I had always grew up with like most of my family are in manual labor or other things like that. So using my hands, like I grew up on a farm. Well, near a farm, we didn't own it. Wish we didn't be rich. We were farm workers. And so I grew up and I was just like, this is amazing. It combines my passion of actually hands-on stuff, using my brain, being close to people, and you see people slightly more often. This was how I saw it. You saw patients more often than the doctor would. Like the doctor would often only ever see them when they're unwell, those things that I saw in med school. So I was like, you actually get continuity in a relationship with the patient. Not a friendship, but like a relationship from that point of view. And I was like, that's pretty cool. Ultimately, I was in med school, right? So it was hard to change. But some of it was beforehand. And I played a little bit of football, like sort of semi-pro standard, and had the odd physio and the odd injury. And so I never had a doctor, right? So I never really exposed to it from that point of view. My experience with doctors before med school was my family being unwell, right? So it was never like a really positive experience. Whereas my stuff with physios was, I'm injured, you get me better, I go back to what I want to do, which was real football, soccer. So that was sort of where I was at. And it was probably one of those just moments in your life when you're 17, you're talking to a careers advisor and they point you in a certain direction. And you just, I don't know, it's very hard to try and choose your career when you're that young. And that's probably advice to people is if you don't know, that's why I did a lot of stuff. I did lots of orthopedic surgery experience to know that I didn't want to do that. I still did experience in cardiology and other things because you can see athletic people in that. Just because I like combining sport or athletic or sporty or physical activity, let's say, with medicine, it didn't mean I had to be sports medicine. There's various disciplines in my world. It's the same with physio. If you're on the fence, one of the best things, even if you say that's actually not my cup of tea, or over here your coffee, probably, you can certainly benefit from going and learning that early on. So experience, even if you don't enjoy it, is still valuable to you.
There's so many broad areas in medicine and in physio that you can go into. It's advice to try a lot of things, and that experience compounds. It's not wasted.
Yeah,
everything you did, you will add and you'll use in the future.
And people, just to talk to that, Luke, that's okay, because people often want to get to their career where they see their mentors or their career idols as quick as they can. And I think, I look back and I think like some of my best communication skills that I have learned when I did oncology, so cancer-related medicine. So when you're listening to someone who's dying and talking about things, you have to listen, right? There's just an element of you've got to switch on, and it's active listening. You can cruise through a lot of stuff, and then also having to tell someone they're going to die and tell their family, you really are quite careful about your words and your plan and what you say, your body language, and all of these things. And I think that my hematology, hemonc it's called, so often people die with leukemias, that's in hematology and cancers, right? So that was invaluable for me as a sports medicine doctor, but no one would really apply to do that and go, that'll make me a good sports med doctor. But it was an experience I sort of had to do. But even if I didn't have to and I chose to do it, it really helped me.
That's really interesting. Let's talk about a typical week for you as a sports and exercise doctor. And can we call you a sports doc? Because we're in Australia. A lot of people say the sports doctor, but the official title, that's a sports and exercise medicine.
Physician,
or sports
doctor.
Physician. Yeah.
I get a range of things, doc, Westie, and then I get less savoury things usually when I've run onto the field. So you can call me whatever you want, but sports doc is fine. Typical week, I laugh, and I know I shouldn't, but because it's probably something my wife would ask me, like, well, what are you doing this week? And we have a planner up on the fridge because I don't actually have 1 week that's the same. And that's even to the point of I don't have 1 week financially. So every week I earn different amounts of money, which makes it I'm self-employed, makes it very, very difficult. Like, don't cry for me. Obviously, we do well for ourselves as doctors, but it's all very strange. And so what does a typical week look like? For me, I'm the head doctor of an AFL club and I'm also the head of health, so sort of 2 roles there. But it will mean that in pre-season, I'm spending sort of 2 days there at minimum, and it may be 2.5 with 3 doctors at our club. In season, it depends. We're sort of like an interstate club, being the horse, because we go to Tasmania 4 times. So we do 10 with pre-season, 11 interstate trips. So that might mean 2 nights away from my family. So that increases the amount of time I'm doing with the footy club. But in season is probably going to be, if you include game day, a minimum of 3 days with the club. Then I work at 2 different clinics. So the first one is Alphington Sports Medicine Clinic, which is in Northcote, if you live in Victoria. And the second one is in the city centre, Melbourne, CBD Physiotherapy and Sports Medicine, which I've sort of more recently joined. And I love that. So I love the balance between elite sport, where you can sort of see where you can push the boundary of performance and where medicine fits in the optimization of performance, but maintaining health. And then in the clinic where I would see people, I always see people like myself, just normal people, but all the way up to people that are, actually at international standard where they don't get good medical support. And I also look after people that are really physically inactive. So the way I would describe it to someone or your listeners would be, I look after people that either have had an issue with physical activity or need physical activity to help them. And that might be a diabetic or someone who's obese or got hyperlipidemia, so high lipids and cholesterol, and we need to get them more active. And how do I do that? And we're quite well placed to do that because that's part of our learning across the fellowship training of what type of exercise, how often, and also if they have an issue during their clinical journey with that, we should be able to help them. And then the last little bit is a teeny bit of surgical assisting, whereby I'll go in the theatre and be the second surgeon, if you will. And I do a little bit of that, probably works out of just over half a day a week. Yeah, but with that is probably, if I'm being honest, because it pays well. And I really enjoy being part of a team, which it gives me that more so than in clinic. It's the same sort of team. It's a diverse team. So you've got nurses, surgeons, anaesthetists, scrubs, techs, all this sort of stuff. And it's quite fun, and I get to control the music, which is always nice.
What do you do in the surgical assisting? I mean, I've observed surgery and I have an idea, but for our listeners.
Yeah, and I told you my background was coming from sort of working class, and I was farming, and I love just grafting. So for me, I get very involved. So bringing patients from the ward in the theatre, I'm flipping beds, making beds, putting braces on. So typical on a Monday, I would do shoulder, assisting in the shoulder. So essentially it's preparation of the patient all the way up until the point the surgeon needs to see them. So that is getting them involved, obviously trying to talk to them, answer stuff, setting up in terms of positioning, we put things called chloroprep prep on their arms and get them sterile. And then the surgeon would often come in and do components of it. And so with shoulders, if we're doing an instability, I'll be screwing in, helping hammer in the screws positioning. I do the camera work, and then at the end just close up and do that sort of stuff. So, bits of it, and I get paid a lot less than the surgeon. But
you love it.
Yeah, it's good fun.
What do you get out of it? I mean, that's the description of the work. What are some of the knowledge and skills and insights you've got into the post-op rehab that you got out of doing that? There's
a lot of that. I mean, that's a good thing as well, because I only do it with sports orthopedic surgeons. So, right, there's an opportunity to ask questions. And this is a great tip for your listenership, is build up your sort of network of professionals that you can share cases with, so you can learn from them. So experiential learning, so that you don't need to make the mistakes of other people. The best thing I've ever done in my career, a guy called Dr. Michael McDeasy, get a mentor. And I used to meet up with him every at least 3 weeks, but it was more like 2 weeks. It started being a coffee and it transitioned to a beer, which was nice. And we would go through cases, his cases, my cases, and all this sort of stuff. So when I was a junior, it was invaluable, and it was great. When I got into sport, I'd say, look, he was the head doctor of the Hawks at that time. So I'm going to run this past the head doctor of the Hawks. I just want to do the simple stuff really well for the first 48 hours. And I was at VFL, and they were like, yeah, that's amazing. So it gives you like a bit of rep. It also gives you a bit of time. So having a mentor, very, very important. But yeah, back to surgery, it gives you the opportunity to chat about things with those surgeons. You actually get really, really good appreciation of anatomy. So that's actually pretty useful. For me, I actually need to suture and stuff game day. So I keep sort of like skill set up that otherwise I would never do until I needed to do it. There's a bit of enjoyment, there's a bit of finance, and then there is a little bit of learning about, as you said there, rehab and stuff. Although I would vouch for the role of the physio over the surgeon there. The surgeon can talk a little bit about what they've done and how long physiologically they think you should respect the fact they've got sutures versus no sutures and all this sort of stuff. But as soon as a physio starts to tell me about rehab, I sort of, sorry, not a physio, as soon as a surgeon tells me about rehab, I sort of go, okay, don't overstep your mark here. So they're there to be excellent technicians, but they're not there to run rehab. That's why we've got excellent physiotherapists and other people that are involved in the rehab journey. So I probably don't go there to learn too much about rehab.
But of course, the more we know, and work together.
So, 100%.
Yeah,
100%.
absolutely. So I've observed surgery. Do you encourage physios to ask the question, can I observe surgery? And they might have similar insights to you. For those who haven't observed surgery before, any tips for asking nicely, getting in there?
Yeah, I think I did say during this podcast, we're all doctors with have egos. Those with bigger egos are attracted to surgery. So if you say, look, I'd love to see, I've heard you're really good at surgery and you're very good at teaching, you blow their ego up, you're going to get in a bit easier, which is one nice thing. Another way of doing it is if you refer a patient to, and if you're not at that stage where you actually have the ability to refer, if one of your mentors refers patients in, can you follow that journey through? And they're often like, yeah, that's fine, come and see your patient. And then when you're there, they'll often just let you stay for the whole list if you want to. We often have physios come in, and it's often the referral pattern that gets them through, right? But and most surgeons don't really mind. So getting in the door is one thing. I think, what questions to ask. There's a balance when you're in the theatre of you want to make sure you ask questions, but you don't ask them at the time there's pressure. So because if my top tip would be try and read the room. So if everyone's talking a lot and then suddenly it goes quiet, that's not the time for you to ask a question. That's the time that shit's hitting the fan and you need to go, okay, we just need to let people think. Because there's actually is a patient, a real person on the table. And another good time to ask questions is in the tea room, before the surgery or after the surgery, or when, for me, I'm the assistant prepping things and the surgeon's sort of looking at the scan before they go and actually do the operation. You might be able to go, can you just show me that scan? What is it that we're doing? Can you show me the labral tear or whatever it might be, the ACL issue? And then often you actually don't need, if you're with a good surgeon, you often don't need to ask that many questions because the surgeon just takes you through it. So don't get too worried about, oh my God, I'm going to be in there like a lemming. And I'm addicted. I love teaching. So often I just do it when I'm assisting. And then obviously follow up afterwards. And then, it's a good way, if that's your way of getting in contact, get their email and then send them a nice email that evening. Thanks so much. A little bit of, and this is one of my tips to your listenership is once you've had an experience, and I used to go to conferences and I'd like ring mark 5 names that I wanted to meet because I knew they'd be good for me, and I would go and talk to them, but make sure you connect straight away. So I'd get their email, and you can do that in theatre, you can do it at the conference, and I'd email that evening to them, and I'd always keep putting something about, so if I'm in surgery, I would say something we saw, an operation I did, or if it was a conference, what I spoke about, and then in 3 months' time, when you email them again, they might look at that thread and go, I actually remember this person because we discussed something, and I'm relatively out there at a conference. I'd always say something relatively memorable, let's say stupid, memorable, rude, whatever it was to the person who's a speaker, and then I'd mention that, and then they would remember you. And I was at a tactic. I used to see going to a conference like a game, which made it more fun because to get to conference, I didn't have much money, so I used to pack bags, I used to clean floors, I used to offer to work behind the bar and serve the drinks for the social function so I could get in for free, and the amount of stuff I did for that. So they are long days, so you have to make it fun. You're knackered. But those are other tips going through. But yeah, you go back to the surgery, just ask. If you get 5 no's, you're still at the same point, which is you're not in theatre. But if you get 1 yes on the 6th go, you're in. And so it's a lot easier. And when you're there in the tea room, there'll be another 3 surgeons, and they might introduce you and say, oh, I'd love to see some knees. Do you mind if I come in? Etc.
And for anyone who's not a health professional, all of this is done with the consent of everyone involved and done confidentially. But you just, when you get into environment like that, and you're not a surgeon, you learn so much. On your networking tips there were really good points as well. Zuzana has had a similar strategy when she was a young physio. Oh, you mentioned the boss earlier. Zuzana sent her a text. She's dropping Henry at the at tennis at the moment, and she will hopefully join us for the end of the conversation. But Zuzana's tips for conferences were the same. She used to have people that she wanted to talk to, and it was always a hook that had nothing to do with their work, like learning something about the person or having something that they will remember. They've had 50 conversations about the presentation they've just done, and they're not going to remember you agreeing with them on that. So, and people love to help. So people generally love to help other people, mentor, and like to have questions asked. So I think they were really good tips. Hey, can we go back to referring people? You mentioned referring, so potentially following somebody through surgery, or perhaps you've referred to the surgeon and following through. What about for physios? Let's just do the basics. And of course, we're just talking the Australian healthcare context, but in general, can physios refer people to you, or are there other options? Some sports medicine registrars, physios can refer directly to, for example. What are the rebates? So do people have to pay more if they're not referred from their doctor versus the physio? Let's talk about the practicalities.
Yeah. So to both of those, so for those listening, a registrar is a training grade, and a physician or a sports doc, as they're probably called, we've done all our exams, we're fully qualified, if you will. The registrars are still very good. But to both of those, and this is quite a misconception, actually, and I lecture to physios about this, which is both of those physios can refer to either. Right? People often seem to think that I need a referral from a GP to come and see me. I do not, and I would probably say, because I work and I lecture to different physio clinics, I now end up knowing a lot of physios, and they put it to the patient like this, which is, you can go and see your GP, and that initial consult, and obviously if you're going to follow up lots, you start to lose. If you think about it, you spend more money rather than lose. But that initial consult, in terms of the difference in rebates currently, and I'll come on to why I say currently, you might be paying $30 extra. It's about $30 to $40 extra for the initial consult out of pocket compared to what Medicare will give you back. And again, that's for Australia. But if you've got to go and see the GP and pay the GP, and you think about your time, how much that's worth, versus, and compounded by paying the GP, if that's more than $40, you can obviously, if it's going to be an ongoing thing, you can see the GP. Where it does change, and I don't do any PRP, and I don't do many injections. But if you're going to do or have from a sports physician an ultrasound guided procedure, the sports physician can get you a lot more back if you've been referred by a GP. So there are certain members of my colleagues who do a lot of injections who insist that everybody has to have a GP referral. I don't, and I say a lot of us won't. But yeah, so ultimately, physios can refer, patients can come in on their own, physios can refer, doctors can refer.
Just to define referring, we're talking about usually an email, letter, follow-up phone call, an ongoing communication, you're working together, versus a suggestion to, you can suggest that you could see a sports doctor, and then they may end up with you. And they can walk in off the street and make an appointment with you as well.
Yeah. And ultimately, so every single patient I see, I write a letter. It sort of becomes a form of medical legal document, but every single patient. So even if, let's say, you have suggested someone to see me and they see you, rather than it's a friend, if you clinically look after them, I'll often include you in the letter with the patient's consent anyway. So in a way, that was a loose referral, if you will. It's a suggestion. But yeah, I get a mixture of communications. From physios, specifically, I'll get phone calls, texts, via email. It might be through the clinic. It might be a letter that the patient brings with them. And so ultimately, it can take various mediums, that referral, if you will. If it's a GP and it's a formal one that will get Medicare rights, that has to be on a piece, it's a piece of paper or email that has address, name, and that sort of stuff. But a lot of physios I've worked alongside over the years, it will literally just be like, Westy, a thing like this patient's come in, help, like sort of thing, and if you can. And so, the difference again is the rebates. And like I said, currently, the college has just been accepted to get access to better rebates. We were put originally on rebates of same as surgeons, which is very poor for the patient. It's not a lot of money rebated, because the surgeons make their money from theatre. We've now gone on to a special, or we will be going to a special rebate. I'm not exactly sure the numbers, but I think it's, instead of getting $80 back, they're looking more like $160 or so. So it's a significant amount more, which hopefully will mean the patient, there'll be an increase in fees, but hopefully the gap fee comes down so everybody wins type thing.
Make it more accessible for people, and
Correct.
more likely for someone, if they need to see a sports doc, that they'll go there.
Correct.
So in terms of that communication you were mentioning, I know you very well. Westy, help. That could be more.
Yeah.
Okay, so I might provide some more detail. But in general, and maybe speak to the new grads here who are writing their first letters, referring, emails and referring to a doctor. What do you really want to know? Like, because there's a lot of detail in rehab. There's a lot of assessment that goes on, of course, of physical function, outcome measures. What are the key things you want to know about the progress of a person as a doctor when you get an update?
And I think that's it. I think so. If we can split that update into a referral, and then once we co-share a patient, an actual update ongoing, and I love both of those. So I always say to the physios I work with as well, don't waste your time. This is not about impressing me. And I always get worried that people are there like, because I have the title doctor before it, people need to try and impress me with a 2-page, one-page thing, and it needs all these Nord board values, and it needs this and that, or I'm gonna judge them. Like, because everybody, obviously, if you get on the Twitter, X, and all those sort of things, they can, or some people love, and some people can passive therapies. And so I'll often get letters from physios going, we've done some passive modalities, but that's only to help the strength. And I'm like, passive modalities can be really useful. Everything has a role for different people. So first is, you're not there to impress me. I would say what I'd like to know, and also actively try not to take people's diagnoses or even patients' diagnoses. I try and make my own input. I'm not saying don't tell me what you think's going on, but what I really want to know is, how have they gone with the period of time you've been with? So I would love to know, I've been working with them for 2 weeks, I've been working with them for 2 years. That gives me a little bit of an idea of where they're at. Have they got better and got worse? What's their journey been? Is they someone that's intermittent or not? Is there something changed? Anything that you think that is outside of just that, which might be family things, other stuff that is going to promote me to ask questions that they may not. So they may have confided in you, has been, and you may not need to tell me everything, but it's had a difficult time at work. And that's going to make me go, geez, this 1 year of pain, I really need to go into that biopsychosocial model of pain and think about things which I'd like to think I'm okay at, outside of just the injury here. So you might put in that email, has had a really difficult time at work and is struggling with sleep. That is golden, because it gives me the opportunity to talk to the patient. Because often the patient's seen their referral and I'll go, hey, let's talk about this. Can we take some time here? And it gives me an invitation to talk to people. So don't be worried about that. There are some bloody incredible physios I work with who ultimately I've lectured, we share patients, but even if I've got a bone stress coming in, they're talking to me about periods, diet, menstruation, diet, and growth, things like this, and that's just awesome. But my main thing is, I just don't want you to feel like you have to do extra stuff. I want to know how long you've had them, what you've tried. So that is very useful. So that's where I probably would like the detail, because often patients come and say, I've had physio. What does that mean? Like, there's good physios, bad physios, there's good doctors, there's bad doctors. And so if you can say, like, I've had them in twice a week, once a week, this type of thing, doing supervised exercise versus non-supervised, that we've worked on posterior chain, lumbar pelvic control, whatever you've been doing, that gives me a little picture I can build in my brain or my head of where this patient's journey has gone, rather than, or if you say, Luke, I've seen this patient twice in the last 3 months, that they struggle to make appointments, I can go, look, this could be just an issue of adherence to what you're asking them to do, versus they've been in our athletic youth development for the last 6 months and they're really making and that's a weekly program, and they're not making any improvement. So that helps. Don't worry about it. It's probably number one. Time, what you've done, and if there's anything you think's key about them as a person, not just the injury, that would be way better than the usual.
I wish I could ask you that question 20 years ago when I was starting out. That would be really useful and hopefully others find that useful, that summary. So there you go. What about, so another sort of practical question. Person most likely needs some investigations. It could be as simple as an X-ray or MRI or something more complex. We keep it simple, and the person has a positive ankle testing, Ottawa ankle rules are positive, and that's indication for an X-ray. And the physio refers for the X-ray on the way to you. What about when it's more complex? You could do an ACL if you like. Do you prefer them to get them to you and you arrange the MRI, or do you think for the physio to get that started? Does it depend on their experience? How do you like to work?
So as you were talking, I remember one other thing I want from the physio referral, or even the update, is what you want from me. So that can lead into this, because some physios are like, I want a rebatable scan. But ultimately, to go back to that question, I would suggest I would ask that you talk to the patient about, do they want the scan before they get to me? And then partly that's a finance thing. I can get rebatable scans or MRIs. So X-rays, I get for free, and CTs I get free, but I can get MRIs for free. So if that $350 is something that's very important to the patient versus time, that's something I suggest, and I do suggest to my friends that are physios, is like, talk to them about it. Say, look, it might be worthwhile if you want to go in, you've still got to pay Liam or whomever you're seeing money. They can save you $350, but you may also need to see them as a review appointment, which is, they're $100 out of pocket. So they are saving money, but it's about the immediacy. So I really don't mind. X-rays, my top tip before you do anything, investigation, if you're doing it so that I can interpret, is put as much clinical information in that you can, right? So partly so they get, because I interpret all my scans, but they do the right views. So if you're worrying about, if you just do wrist X-ray, but if you're worrying about scapholunate and you talk about that, they might do a scapholunate series, which has different clenched fists and all the deviation, rate of deviation. But if you don't ask for it, if you just put trauma, this, they're not going to do it. And so you actually organising has meant that you haven't organised the right scan. And that's the only other thing, is thinking about what's the right scan. So for instance, if you're thinking of a PARS, I wouldn't do an X-ray, I wouldn't do a CT. So that's a bone stress in the lumbar spine because the MRI is gold standard. But for some other things, it might be that a simple X-ray is just fantastic. So if your ACL, example, if they're 14, get an X-ray, because that's great to rule out where they've actually had an avulsion and things like that.
And whether they need to be, how critical it is to be non-weight bearing immediately. Yeah. So maybe if we summarize that, it could come down to the immediacy of it and the discussion about the costs and putting them in charge of how they want to run it, and maybe some education of how it works, and that they'll see you, there'll be a follow-up, and the physio will be informed, you'll work together. There's a bit of work to do for the grads when they have to figure all this stuff out, isn't there?
Yeah, it's really hard, but it's also fun because you develop a network, right? And you're going to make mates, friends. I've got loads of physio friends, and then it's good. And so I often get texts of like photos of random swollen knees and things like this. Do you think you should do that? And I help from that point of view. And Zuz does that as well. And I think that the other thing for me is, if you're going to organise an MRI, I'd love it that the patient expects that I'll go through the MRI. If they chase up the report, that can create so many more problems, because the report will describe everything an individual sees. It will not talk about what's clinically relevant. The classic one is someone, every week I will get a chronic lower back pain that's had an MRI and they're 60 and they've got a disc bulge, which looks like 10 million times better than any of my footballers do. But they've come in and they're requiring all these strong opiates because a GP's organised an MRI and they think they're about to explode. And so MRIs can be powerful, or scans can be powerful, and they can be disruptive and destructive. So I think it's a case of, I often say when I lecture, if you're going to go through the scan, make sure that you are educated enough to interpret the scan and challenge the radiologist's report, because they might be sleep deprived because they've got kids going through a divorce and it's 6 p.m. on a Friday and they're finished at 5 and they're going to dinner. They may not give it the most respect it deserves, but each patient you look at, you thinking 100% about them. But the radiologist doesn't have the relationship, doesn't have them there, and it may not be the greatest report. And if you're basing your entire opinion of that consult with them on a report and it's wrong, you're setting yourself up to fail. So
I want to put, Zuzana might be arriving. I can hear the door. That's right. We'll get her in here. I'll put a Zuzana statement to you, see what you think, which is, I hear her say a lot with her clinical work, is that if you suspect bone, if you suspect a fracture, yes, you might have a role in managing there, but it is also a medical problem and you should have the doctor involved. Are there any exceptions to that? I mean, let's take obvious ones: lumbar stress fractures, navicular stressies, obviously fractures that are going to need orthopedic review. Do you think anytime you have a bone stress injury or a fracture, you should be involved? And if so, why?
Yes and no. So if there's a possibility of overtraining, low energy availability, REDS, I definitely think a good sports physician is worth their weight in gold. We work as a team within this, especially if it's someone who's in often those case studies you give me there, or examples are junior talented athletes. And people that might be really important in those are sports psychiatrists, accredited sports dietitians. I have a little subspecialist interest in bone stress, and I lecture on it and do this. So I'm a bit like a shit, excuse me, I was a shit magnet, but I say it, and I said it for it in Melbourne. I'd say at least a fifth of most of my clinics is bone stress, and it's it has become something. So I hope I'm not terrible at it. And I'd say I with 1 in 3 will eventually get them to a sports dietitian, and maybe 1 in 4 to a sports psychologist. And if they haven't come to physio and they've just come in on their own, like there's going to be that and all these sort of things. So that is a huge team framework that's needed behind that person for them to succeed. We know the statistics are that if you've had one stress fracture, you're more likely to have another than the person next to you, especially in certain areas that are higher risk. And if, unfortunately, it's much harder for our female athletes because their stats are against them even further. And so we need to help these individuals. Part of rehabilitation for all of your listeners will be managing the injury but preventing it happening again. I think bone stress, you talk about that. However, when I say no, that is if you've done an x-ray and they've had a lateral ankle sprain and you've got a 1 millimeter avulsion fracture of the fibula, like what am I see a few of those every year. I'm like, you guys are more than good enough to look after that. You just need to see that as a ligament injury, and that's it. Hello, Zuzana.
Zuzana snuck in, and she was trying to hide there. I've got her headphones on.
Yeah.
Did you hear her? Nice and clear.
Yeah, I can hear her perfect.
Oh, perfect.
Well, you know what? I just asked a question, which we've been talking about a bit behind the scenes. If it's a bone, it's a fracture of some sort, bone stress injury or any sort of fracture, the statement was the doctor needs to be involved. And then Liam was giving our listeners some context on the higher risk stress fractures that definitely need multidisciplinary care, and then some examples of what ones that physios could manage, which has been really interesting. You can see there on the screen some of the topics we've already been through. So
perfect.
And I would say to that, I find it rare now where I get a bone stress injury that I don't do bloods on or something like that. And so there are extra things that I might well be doing that I presume are less available to physios. You can ask your GP, but are you getting the full workup, or DEXAs and other components like that? So I think we're learning more and more and more, probably over decades or 5-year periods, about bone stress, and that what people used to do, you've got your tibia bone stress or whatever, is rest, graduate, return to run, play sport. Is I often say to people that's really not cutting the mustard. Like, why are people paying you? You all have pride. You want to be better than that physio down the road. We can do so much better than that. You have this individual for a period of time, and your role is not only to get them better, it's to prevent it happening again and educate them. And that education might be much more than just tibial bone stress. It's about what it means to be an athlete, the importance of sleep, the importance for young girls of having a period and it being regular, a little chat about fertility there, linking them in with their family and diet and carb and all these sort of things, right? And you build a young lady called Evie, who's just an amazing girl, who's 17, and we've just finished a delayed presentation of navicular stress fracture. Saw a GP, organised a CT. It was a poorly organised CT. It was looking for metatarsals. It was very poorly, therefore, reported CT because there is this huge navicular crack that just was not commented on. So the GP says, no, you're fine. We all know, and Luke, and as you know, and your listeners will be keen to know that often they're not that painful. And so this girl goes on pushing through with games because she wants to get into these teams. And ultimately, it has taken us about 15, 16 months to get her back to now towards looking at full training. She's a sports academy school. And so I think about that and the conversations I've had with her about so many different things, going through to body image and Instagram versus dietitians who got involved and school and with her parents and not having parents in the room and all these sort of things. Like, your role is not limited to just getting someone to heal. Or if you see it like that, I don't think you're fulfilling the potential of your profession.
Yeah, look, when I see them, I just go, look, and I know they haven't seen a doctor, and particularly I like sports doctors just because you're that gap between sort of a GP that has that limited time. But the biggest thing that a sports doctor does is the appreciation of keeping in sport, modifying sport. And and understanding what it needs to get back to not just sport, but being good at sport. And I just go, look, yes, you've got this stress fracture or stress response even, but now it's a medical thing. We need to get medical input as well, because I think that's the key about sports medicine, is that you work as a team.
And Luke mentioned it before that I'm a non-physio, I'm a muggle, and you may not have many sports doctors on your podcast at the moment. But to advocate for us, I'd suggest if you get chest pain, you might consider going to a GP, but you probably wouldn't go straight to a cardiothoracic surgeon. You go to a cardiologist. And I think in society we've missed that. You go from GP to orthopedic surgeon if you get medical input for an injury, whereas sports medicine is that gap. And hopefully that helps listeners that haven't had much exposure. And I think a lot of physios may not have had much exposure. This country is much better for exposure of our profession. But still in the UK where I'm from, in the Premier League, they will describe injuries as like knee knocks and things like that, which I've seen ACL described as a knee knock, which is just mental. And so they're not using the media to actually push it. And so, it's really hard. And I agree. Our training is, different in a way to GPs and those sort of things, which is using, I actually wrote a note because listeners give me a few ideas of what I was going to be saying. These aren't fully off the cuff. And one of the things I did put in here was a little bit about treating, if it's an athlete, still treat them like an athlete. You've got to think about what they can do, not always what they can't do. Otherwise, you'll just lose them. Like if you've got a swimmer and you only give them land-based stuff, they literally breathe underwater. They're an aqua mammal. So if you cannot keep them in the pool, you'll find it very hard to keep seeing that person. So even if it is they are doing a squat in the water, even if you don't think it's that useful, you will create a relationship. If they're not in Speedos, they're not happy. Right, so little things like that, and GP is a very, very, very hard job. You need to know a little bit about everything. You're not afforded the time usually to be a specialist in any area, and you've got to find that one person in a week that might actually die. And the other 99% could probably wait, or 10% are actually just maybe over exaggerating their symptoms because they want to be off work. Like I couldn't do it. It's very hard. It's not their fault.
It's important for people or listeners, especially grads and students, to understand that context, understand what a GP has to do, as you've summarised so well there.
Yeah, don't. If you've got a patient and you actually like them, if you don't like them, maybe do. But if you've actually got a patient you like and you've got a concussion, do not send them to a GP for clearance. You may as well send it to your dog because it's so unfair. The GP can't do that in 10, 15 minutes. And I see people that come in with 3 concussions in a season. They've seen their GP and they've done what they can in that 10 minutes, which is just like an AVPU and things like this. And you're like, man, this is so unfair on everyone, the patient. And I think you have a role, the referrer, to say, look, look after yourself. This is where you've got to go. And they just want, and I understand, like I've looked after local level footy, and you would never do it at the Uni Blues, but like things like that, you just want to be, the players want to be out there and they might choose to use the GP, but there's not much you can do about that.
Mm. But I think to your point with the swimmer doing the squats in the pool, I think sometimes what we forget, giving exercises as treatment is that mental aspect to sort of recovery, etc. And I mean, you've seen it, and this is where medical, I find, can be really, really good in terms of understanding the mental health aspect, which I think as physios we probably don't appreciate as much. And that sort of that rehab continuum, I've seen it a lot in terms of someone gets injured and then they go back to, successful return to play, which is fantastic. But then they get re-injured and they get back into that rehab phase where, they lose that contact with their players, etc. I mean, could you talk a little bit about that, the sort of mental health where, medical can come in?
Yeah, huge. And so I have 2 worlds. I live in the elite sport and clinic, and I say to both, I often tell patients little things that I've built up so that it tells me. I'm not really telling the patient, I'm just reminding myself. One of those things is every injury has a structural and a mental component. I normally say a confidence, not mental, because you get them offside. But ultimately, it really does. Now, even if they're out for a week, it's more structural than it is going to be confidence. But if you've got an ACL, the return to performance has a huge psychological component that you may even. So, for instance, if our player a Hawthorn player did their ACL at training, they have to revisit the trauma every day they go to work. Versus if they did it at the MCG, or which we play there a bit, but if they did it at Optus Stadium, we are going to go there once a year. If we play up at the Gabba, sometimes we spend 3 years not going there. So it's less of an issue, but it's about thinking about that during the journey. You're going to spend so much time with them, but it's a case of, so if they've done it at some park they're going to play at during the year, they need to go there and do a training session there, do some running, go run across the ground. And you might not think about it much, but that athlete, and don't be scared to ask them, like, do you think about your knee before you go to bed? Do you think about it when you wake up? I always say to the patients, like, if you were to talk to a friend you haven't seen, they've come back from travel for 2 years, how long would it take them before you told them about your knee? And what would you tell them about that? If you had to give them a rating of how confident you are in it out of 0 to 100, so a percentage, where are you at? And just simple questions like that. But I am you should tell, a bit passionate about this area because I think that we treat injuries, we don't treat people. If your listeners have not watched Patch Adams get around it, it certainly, I was lucky enough to watch it as a med student, and it did hit me a bit. And I was like, wow, this is insane. Like, medicine is built around disease. It doesn't actually want people to be healthy. Like, it was partly why I went into sports, but I was like, this is a bit crap. But you can get paid a lot. So it was all very difficult for me. So I think that if everyone has different stresses. So if I am a mother who works stacking shelves at Coles and I have a shoulder injury, that's going to affect how I can breastfeed versus how I can do nappies and how I can stack shelves. But if I am a young AFLW player and have a shoulder injury, that's going to affect my ability to keep my contract, and what does that do to my career and my income? It's the shoulder injury, but the context is what's important. And if you don't think about that and talk about that, you're just treating an injury. And so there's a limit to all of our expertise, but the first thing it begins with, whether you're a physio or doc, is just talking to the patient and then actively listening. And just show, I always tell people and people I mentor is that it's the phrase, and I actually don't know where it came from first, which is, I think it was Roosevelt, but I always say that people don't care how much I know until they know that I care. And that's really hard in clinic. It's less hard in my elite sport role because they see me all the time. I'm asking about their family and doing things like that. Whereas I need to quite quickly show to patients in clinic I care about them. And that is asking about them, about their feelings. And so I would say most injuries in elite sport will see a sports psychologist. And this is an in for your listeners. If you're not in that world, you can say, I understand that this happens. And if you are, I say to my patients, do you know what? The person that would be most important for you at the moment, if you were in my football club at the Hawks, would be the sports psychologist. They would help you. And that's what I see year in, year out. They would help you more. And they're like, what are you on about? I said, well, in elite sport, having a sports psychologist is the most beneficial thing. And all of our athletes love it. He's actually oversubscribed, or she is into clubs. Whereas outside in the community, it's made out that you're weak or there's something wrong. And there's a huge disconnect. And at least broaching that. And a lot of injuries, so for instance, that injury I was talking about, saw a sports psychologist, and it's so beneficial. And so, yes, there is a component. And if you're going to dip into that world, you need to have thought about how you'll do it. So the entry, gaining permission to talk about it, because you can do it that way. You can say, hey, I think that injuries have a real big issue with psychology or confidence. It's okay if we talk about that for a moment. Are you ready to do that? So you gain permission. If you're going to go as far as that, I would feel comfortable with some. So if I've got a patient that comes in and I know that they've got OCD, so I know that having routine and being at sport and being at training is going to be important. And I can see that they've got cut marks on their arms, and and I've got a history from the GP report that they've got depression, things like that. I would feel comfortable and competent to start talking about self-harm and suicide. What I would suggest on this call is, if you don't feel comfortable and you don't think that you can deal with the answers that you might get, don't go too gung-ho in this area. Please, because you can do more harm than good. And that's where potentially, if your son asks and say, where's it getting? They go, this is really getting me down. That is a flag to say you need something medical, someone medical to help you. It's just about getting the best for the patient.
We've done mental health first aid training in our roles as educators, really useful. and encourage anybody to look at if you're a student listening to this, you've got a variety of resources and universities to look at and reach out for help. But that's a really important point. Well, I do have questions, Zuzana. What would you ask a sports doctor? This is the whole point of this episode, which has been really good, and I think we've really addressed it, is to really introduce you as a specialty to some of the people who may not know. We've covered some of the practical questions of rebates and referrals and accessibility in the Australian healthcare context. What would you ask Liam? Put you on the spot. I think what I hoped you'd come in and follow up a little bit about some of those conditions. So we talked about stressies. You've got a special interest in stress fractures, and you touched on concussion and ACLs. Any other conditions that both of you see commonly that you might that might be really suitable to work with both a physio and a sports doctor?
I think as physios, we're very good with the musculoskeletal side of things. But if things aren't adding up, just making sure that you're covering all your bases. If they're getting constant pain, or the pain is not behaving as you expected, or you're giving some treatment and it's not behaving, it's not improving, etc. It's really important to understand. And I think as physios, when we graduate, and I particularly found this, I felt like if someone wasn't improving, then that was my fault. I wasn't doing the best treatment. But understanding, hang on, it's not behaving the way it should. That's where medical can come in. And I think there's one particular case just recently in the last few weeks, and Liam probably doesn't know, but we share a patient, and this patient saw you, and you've done a fantastic job with her because you referred her to Tame the Beast video. Do you want to talk about that? There's loads of bits I'd love to pick out of that, but it's partly I don't want to keep you forever, and people will get bored of my voice. So Tame the Beast is an excellent website, not just a video. So literally just Google Tame the Beast, and at the top right there's a section called Useful Resources, and I show this to a lot of my patients. I used to watch it with them, but it's a 5-minute YouTube video. And what I would say, if you're going to use this type of area of medicine, which is the biopsychosocial model of pain, and to explain how structure and pain are not perfectly aligned, you probably need a bit of a preamble with patients. So before I even get them to watch, I will say, look, the pain that you feel is 100% real. It's a feeling. Feelings are real, but it may not be based on what you think is causing it, which is just an issue with structure. And so what I want to introduce to you is that other things can contribute to our feelings, and in this case, pain, above and beyond that. And that can be biology, psychology, and our social construct. So biology is pretty simple. You've torn this, ripped that, whatever. So psychology, I'll often talk, I get bored, so I change it up. But it would often be like, your glass half full, glass half empty. Are you prone to being a little bit more anxious about things? Are you really easygoing? Are you going to ruminate about this? And the way that you are, and that's individual, can affect how you respond to a situation and whether it's painful or not. And that's in the short, medium, and long term. And then social is a really interesting and complex construct whereby it's how we interact with the environment and how the environment interacts with us, such as how have we slept? How are we eating? What are our current stresses with relationships, finance, university? Here, I'll keep it in linking with the listener. And there are great studies out there. I talk to people about how with people with chronic lower back pain, because lots of people have it, therefore we can study them. If you put them in one room that has a really noxious or horrible smell or a creaky door noise and get them to do flexion, which is what we often think provokes disc-related pain, you give them a rating out of 10, or they give it you, for pain with that movement. You take them straight away, so it's the same person, the same day, therefore the same structure, to a different room that has a really nice, serene noise or a beautiful smell, and you get them to rate their pain. They are different, and that's from beautiful research. And therefore, our surroundings affect our pain above and beyond just structure. And so I talk a bit about the social, but that's what the Tame the Beast. And I always say this video is a lot better than what I've just tried to hack my way through. And I've got drawings and things like this.
And I introduced them to that. On the useful resources, I say, look, we all learn differently. Some people like to read, some people like animation, some people like watching stuff, TED Talks. And so you think about, or podcasts, how you want to learn. Let's start there. And this can go as far as you want it. And I'd love you to engage with it. I would say, this won't work if you do it once. I want you to at least watch the 10 Beats video once every week, because it will get you to think about different things about your journey, and it might get you to just view it slightly differently. I want you to start thinking, are there alternate reasons for why that pain flared with your clinical journey and you couldn't put your finger on it? Maybe you're actually having a real crap time at work, you haven't slept and your kid was unwell, and maybe we can rationalize your pain increasing from that point, not you now need an operation and you're doomed. And so introduce it like that, and it also gives me a common language with my patients to talk about. Is it that thing that's grabbing on and it's the wolf that's doing it, and however they might talk about it. And I think if you can, I've had some really profound results over the last 5 years, really jumping into this, to the point that I probably overuse it and I miss some amazing structural injuries. But I think if you really engage, like I'll never forget, it's actually one of the physios I worked with, her partner who identifies as a runner and is very athletic, and had, I think it was at least 12 months of this bilateral shin pain. And the more I listened, I just got this feeling of it doesn't make sense, right? And we've all had those patients you go, I can't structurally work out what the F is going on. I don't think so. And I really went hard with him with this. And I do a lot of, I become like Wolf of Wall Street. They're like, come on, you can do this. And I'm bagging them up and things like that. And a bit like a lifestyle coach during it. And I think they need it. And I'm like, I believe in you. Like you need to believe in yourself. And I always write, I've got these different things I draw and a piece of paper. The biggest thing I do, and I always shield it so they can't see what I'm doing. I write these massive capital letters, you are safe to move. Right. And then I say, you need to look at that and get that in your mind. You are safe to move. And actually, we need to get you to move to get better. And this guy, it doesn't work this well, but got back to running within 2 days. And that weekend, he wouldn't do this from a bone stress point of view, ran a 10K. And he's not really had pain in the shit, other stuff. But that is the most profound thing where you can have people go like this. But I think that's how I think about that stuff every single consult. And I make sure I always ask people about their life. So I go through, tell me your history, so they give me their bit, and then I'll always pause and go, right, thank you so much for that. Now you've had 5 seconds. Is there anything else you think is important for me to hear about your story? And they'll add in little bits. Then I go in, so I've done my open questions, then I go in my closed questions, and I've already done their medical history and things like that. Because if someone goes, oh yeah, I've got an inflammatory spondyloarthropathy that's making me think, now this tendon is related to your medical issue and you need to be on Humira. So I always start with the medical things first, do that, and then at the very end I say, look, can we widen the lens? And I'm trying to give your listeners ways to approach and words to use. So can we widen the lens and just talk about you? I want to make sure we treat the person, not just the injury. So usually attached to the ankle is you. And so I'm like, what's going on in your life? Can we talk about your sleep and do this? It might take 2 minutes, but that's often the most important part of my consultation. And that's where often I make people cry. And now I've had 2 kids. I cry in clinic all the time.
Yeah.
I cry. My wife popped head in earlier and she would laugh her head off because she knows I have not yet made it through one Bingo and Bluey episode without crying.
Oh, wow.
I'm a crier, and I tell my patients I will cry as long as they get. I'm comfortable with it now. But I have tissues. But when you ask those 2 minutes of questions, that's when you'll often see someone go way off their shoulders. Holy shit, this is what's going on, and you go, geez, that's a lot. And you just got to give pause and go, do you think that could be going on? And you ask them questions to then give you the answer, and that makes a bigger neural connection of shit. This is important.
Did you always work like that, or is that life experience?
No. Mentors. We'll go back to the things that we've been saying all the way through Luke, and now you're doing mentors to help me. I don't think I saw the results people told me I should get with just going structure, drugs, injections, this. And I went to a lot of conferences and heard a bit about this. And then ultimately, like you guys are doing, I actually did a podcast, and I got a lady called Tasha Stanton on, I've got Laura Mosley and things like this. And so I learned about it myself because I was doing it. And I was just like, I've got to start trying this. And look, I'm not trying to bag out medicine. Medicine will be very, very good, but there's a little bit about it. So it's not like they never said, talk to your patient, just talk to the knee. But I felt like it wasn't as rewarding. And now I do run late at times because patients are so freaking interesting. And to give you another flip side, I think we do this terribly in elite sport because you get familiarity. You know this player, you think you know them, but realistically, you've seen them around the club for 3 years, then they've got an injury. You don't know anything about their family. Even if I've seen someone 2 months ago, I try my hardest, and it's often very hard the way that programs are built in sports, not around a 40-minute clinic appointment. It's a 2 minutes before they go out to train. So you need to try and grab them again. But I want to find out, hey, what's going on in life? Have you still got your partner? Is this going on? Because often I think elite sport gets supposedly the best people from clinic. It gives them the worst environment. So that's a really hard thing to get your head around when you first get in, because you're just happy to have the role, but then you provide a really crap service. And so I bring them back to clinic. I didn't feel like I was giving the best. And the more you do it, the more results you. It is a bit. My mates take the piss out of me because they do a lot of injections and I don't do PRP, and they say all these fun things, but it is pretty rewarding. Because then, and you'll see you get a lot of referrals from patients and patients' families and all this because you at least have listened to them. That's one of the things, right?
And that makes a big difference, like particularly in the professional sort of athlete world. They get monitored for everything, and then they get a ding 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 ding. There's red all over them because their sleeping is gone down, their running times have gone down, and all this sort of stuff. And then everyone's thinking overtraining, and then you talk to them. They've had a fight with the missus or the fight with their partner, or something's going on with the family. The parents have been diagnosed with something, and unless, like you're saying, you actually have that time to talk to them. Is there anything else going on? You're not going to know, and you're just going to assume things like, oh, it must be overtraining, and let's change this, that, the other. The other thing,
I was going to quickly talk into that, which. My Hawks players are always just so bored of me saying it, but I always say, like I told you earlier, I say things to them so I remember that that's how I practice. Is I always say, you're a person first to me, you're an athlete second. I care so much about you as a person. And the athlete, that's great, but I grew up in the UK, I don't really care whether we win or not. So there's a bit of that I always say that. And I was going to say another thing, but I want you to ask a question.
No, go.
No, because I maybe forgot, so I'm going to look stupid. So you ask a question and then we'll carry on.
No, I was just going to say, I guess the last year or so, I've worked a lot with a couple of sports doctors in the realm of middle-aged women with tendinopathies, hamstring tendinopathies and gluteal tendinopathies. And I think where it's been really, really eye-opening having the medical input has been sort of that hormone space. Could you talk to that? Because as a physio, I don't think we appreciate or don't get a lot of education on that world, particularly from a female point of view. And
perimenopause, menopause, across the lifespan. Yeah, so much more that we could learn.
Yeah, 100%. And I'm not going to do it justice, but it's also a bone world, right? So if you think about your bone loss, life is much harder as a female. It's so much easier. And I tell my patients, I always say, because you've got to try and break. So a tip for those male, if that's the right term, and I apologise if it's not, listeners, it's hard to talk about periods. I always say, I put my hand up and I always go, look, I'm yet to have my first period. And that just breaks the ice. Right? And then I say, but it's so important to me as a sports doc because it gives me an external marker of how your energy balance has been through your life. So you need to work out ways to approach difficult subjects. But it's also important with bone stress because of the effect and the balance of estrogen and progesterone on bone health. So coming back to tendons, we know around we don't know a lot. There's bits we don't know, but we do know, and it's easy to say that around perimenopause, due to changes in estrogen and even to the point around period cycles, there is an effect. If we go back to what I was talking about biopsychosocial, there's an effect on pain, first and foremost. So hormone regulation infects your feelings, and so therefore you're more sensitive to pain or peripheral sensitization, central sensitization, if you want to go into those theories. And then at a more structural level, like collagen and these sort of things, there is an interaction with those sort of things, and you're more prone to tendinopathies. And often, unfortunately, going through the perimenopause, and it's really multifactorial, it can often make either you, as a pure lineage, put on adiposity, not good for tendons, or you can go as a byproduct and say, well, unfortunately, this can lead to people having poorer mental health, eat more, and put on weight. it doesn't really matter. It's at the end time point, but it does matter because you need to go through that with that person and be multifactorial. So yeah, the issue, but I think that's pretty simple to look at it that way. But you can go HRT, and I don't really like it because we've pathologicalized something which is normal in terms of menopause, but it can be amazing for that stubborn tendinopathy. Okay, and doing those sort of things as well as empowering them to do the key pillars of health of diet and exercise and these sort of things. But sometimes, and the other things that I talked to you there about, so is if you've got a guy and he starts to talk about a tendinopathy and enthesiopathy, so it's usually like insertional Achilles, and especially if it's bilateral, you start to ask questions like, have you got any back pain? Oh yeah, geez, I tell you what, I get up in the morning, I feel like an 80-year-old, it takes 45 minutes to get going. And then you look at their nails and you go, oh, they're a bit weird, they're a bit spoony or pitting and things like this, and you notice they've got psoriasis, and you start to think, and if you haven't, listeners, Google something called ScreenDem, SCREEN, and then space DEM, which is the mnemonic, so you say, for rheumatological questions you should ask as a physio to try and go. And so you're looking at nails, uveitis, so eye conditions, mouth ulcers, abdominal pain, enthesiopathies and things. And if you think that could be the first presentation for someone with an spondyloarthropathy or a juvenile arthritis to go to you as a physio, and you go, hold on, I've tried, and that's one of the things you said is, when would you use sports medicine? If you've done, I'd say 6 consults and they're not significantly better, and it's like it's not an ACL, so you need to go, holy shit, there could be something else going on here. I need to get another physio to get a second opinion, or maybe it's medicine. But often with these people, we manage them and they get onto the right medication and their musculoskeletal things have changed like that. And so that's important. I've remembered what I was going to say, because I know I'm very tangential, which was a top tip for your listener, because this is what we're trying to pack in before I go and do some exercise, is if you have an adolescent or child patient that comes in, right, try and remember to begin every consult with the parent or grandparent there saying, hey, just to let you know, usually with most of my adolescent or child patient, whatever it is, patients, I'll ask the parent to step out for a period of time during the consult. I'll just have time with with your daughter, son, whatever it is, and then you'll come back in. It's usually just a minute. Is that okay? And everyone will go, yeah, that's fine. Because that moment you go, this doesn't make sense. Oh my God, is this kid not telling me something? Are they getting bullied? Is there sexual abuse going on? Something like that. And you think, I need to safeguard here. You've done your mental health course that you're discussing. It will be very awkward because usually there is tension in that room. And then you cannot say to the parent, can you leave? Because the parent will be like, why do you always leave them this? So that is a top tip. If you can say at the very, I think of a beautiful physiotherapist who told me a story of this abdominal pain. They couldn't work it out. They're trying to do this, and went for about 10 minutes. Beautiful presentation. They did amazing. And I said, what do you think is going on there? I've tried this. I said, I think they're getting bullied. And he was like, what are you on about? And I said, this has the hallmarks, vague abdominal pain, or doesn't make sense of something going on. I said, I'm happy to see them, but if you think you've got a relationship where you can just do this, talk to the parent, and ultimately the patient, like, it made me look like a hero, but you just see patterns, right, in medicine. And that kid was getting bullied online and at school, and then ended up going through school psychological services and things like this. And so that's a bit of a tip around, if you see younger people, if you can set up your consult in a way that it will be advantageous to you and the patient, please think about it. I am not perfect. I often forget. But I don't care if people are annoyed. Like if I think it's the best for the patient, I would say, look, I forgot to say at the beginning, this is the time point. Now I've got through these questions. I'm actually just going to have some time on there. It's important you do it. But anyway, I remember that bit.
No, that's good. I've actually got a patient that I will now do that with next week. So no, that I've see, even I've forgotten.
There's so many practical tips here. We're so lucky to have you on here sharing. I know you've got to run. Talking about physical activity, you've got to run a night run to do, and so do I. We've got 5 minutes more to wrap things up.
Yeah, cool. Do you know what? I actually, one of the things, I'm going to take your question because you've given it to me. You could ask it me, but I'll ask it. I'm on a roll. Because one of the things we were talking about and we've been talking around is sort of what should physios do? It's realistically, you were asking like, what makes that good physio?
Yeah, that's the question.
Yeah, and that's one of the things. And for me, I had a little think about this, and I've got to be a little bit respectful, haven't I? And so for me, if I think of a good physio, and it changes in different roles, is the ability to problem solve, because that's what the patients come in. I've got a problem, I need you to fix it. And so if you are closed-minded, I often say to patients, my big boxes I've got is, I'm worried about you, and I'm not worried about you. Then I'll say, you're in that, I'm not worried. Sometimes I'll say, you're in the worried box. But I go, I'm not worried about you, which is great because it gives us a bit of time. I know you don't want time, but it means we can do a few things and see how it goes. But the ability to problem solve, so if every anterior knee pain for you in a female is patellofemoral syndrome, that is not open-minded. Or if every posterior heel pain is Achilles tendinopathy, et cetera, et cetera. So ability to problem solve. And I think the way that you do that is listening to the patients tell their story and actively listening, and not trying to fit them into that box that suits you or your skill set. And if it's outside of your skill set, it's referral. And I think you need to, what we've been talking around is manage patients, not injuries. So that there is a knee that's come into you, and it's really funny, isn't it? And on our sheets, or whatever you'd call it, the roster that you have for the day, often it will just say, this patient, and it will just, in my timetable, say knee. And I'm like, oh, I hate that. And the reception don't do it anymore because I'm like, there's so much more than a knee. It's a bit like in my football club, everyone likes doing meetings and they go in number order. And when I'm leading a meeting, I refuse to do that. I'm like, these are people, not prisoners. They're not numbers. We go by the name. But anyway, so you're managing patients, you're not managing injuries. And if you only manage the injury, you've either missed an opportunity or you're not probably doing it very well. And so consider the impact of the injury on the person. So we gave a little example there of the pregnant lady on calls. It's going to be different than if it's a desk-based worker, than if they're on holiday, and all of these sort of things. And how do you manage them and improve their ability to perform their role? Perform their multiple roles they hold: parent versus teacher versus carer versus athlete. What can they still do that won't impact your rehab? So they still need to be able to do that. So if it is that they've got issues with breastfeeding, you need to problem solve, become a bit like an occupational therapist, which is what my wife does and is very good at. How can you help them do that? And so you've got to think quickly. And you think, well, can you do it on the other arm if you put your arm here? Actually, no. Let's talk about breastfeeding pillars, or let's talk about setup, or let's talk about a chair that can go backwards so you can use gravity. I'm trying to do this off the top of my head. But you need to see patients. You need to talk about issues you have with your listeners, with your colleagues. Hey, I now go, I've done this before. And so learn off other people. If you only learn off yourself, you are giving yourself a speed block of how quick you can get to being that practitioner you could be. So go to other things and go to conferences, talk about stuff, learn from the best of the bright spots if you read your literature. And that would be a little bit of what do I think makes good physio. And then there's that component of know your limits. And that's every profession. It's not just a physio. I'm really talking about what makes a good practitioner. And I think it's knowing your limits. Just because a patient is interesting doesn't mean you should hold on to them, right? We all do this. Geez, you've got a bloody weird presentation. Now, I see this, I think, a bit more in physiotherapy than in medicine, because your role or the way that your job's been set up are really, really difficult. Is you often graduate and then either you have to choose to do a master's or some further education, and you can come out at a relatively young age where you're working out yourself, let alone your career. And then you go into a physio-only clinic, and you're not going into an MDT clinic. And so you can go through a whole day where if you're running late, you don't see anyone at lunch, and you just see patients when you go home. So you don't talk to anyone about anything. Whereas, so if I go into my lunchroom where I'm at Alphington, for instance, I might see a dietitian, I might see an exercise physiologist, a physio, podiatrist, another sports doc, receptionist. But it gives you opportunity to cross-pollinate, learn ideas and learn approaches. And so I think it is bloody hard for physios to sort of widen their scope and do that. But I think curiosity and actually being vulnerable to say, this is what, I reckon the amount of times I tell people, I'd often tell patients, I think I got this wrong. I think the honesty. So honesty and curiosity is slightly different, but it's probably the same thing, which is the curiosity to say to someone, this is what I did as a management plan. Do you think that's right? Now, going through the fellowship, so I've done my medical degree, sports science degree that we spoke about. I did a master's, and so that I had to go through cases and things like that. And then I did a fellowship for 4 years. I had to do all these CBDs, which are clinical case-based discussions. So I basically had to say, this is what I've done. Is it any good or not? Mini KEXs, which people had to watch me take histories and do examinations. This is for 4 years. Every month I had to do these different things. I used to do long case stuff. And DOPS, direct observation of procedural skills, and all these different things. But that meant that you're about 30 when you finish, right? And so I've sort of been spoon-fed stuff, but I've also been vigilated, mentored, whatever, and it's helped so much. But I've been in an area where even now with clinic with Alverton, I've got all these different disciplines. And so if you are a physio and you have an opportunity, this is just my suggestion, to go into 2 clinics when you graduate. One is just a physio only, and one is a multidisciplinary, and you see more patients in the physio, and you might see a bit less in the multidisciplinary. I would suggest you pick the multidisciplinary every day of the week, because you will become the practitioner you feel you're destined to be a lot quicker. And everyone's impatient nowadays. Anyway, so it's probably all a good practitioner. It's not limited to physiotherapists, but that is what I see. Obviously, both of you all think you're great, but that's what I see in those physiotherapists that you might go, how the hell did they get that job? Because they've networked, they've learned, and they treat people. And so that's probably a lot of what we spoke about in this podcast put into the long, short summary.
Well, I completely agree with you, and I've had that issue myself in terms of we had the children and I was coming back into clinical practice because I really was just desperate to get out of the household. Luke was good enough to say you can go full-time, so I went full-time into the clinic, and it didn't take me long to be, and it was just a physio-only clinic, and then I just was booked out all the time. And I just felt like I was not learning, because in the end I was just in the room with the patients. Yeah, well, with the patients, but what you're saying, and I think that's the best thing, is that feedback. Like, am I doing the right thing? Like you just don't know, because you don't have anyone else looking at you. And then I went out and then became a research assistant at La Trobe Uni, and that was really great, because so I did that part-time and the clinic part-time, and then I went into footy at the professional level, and that was just eye-opening, because you go in and it's just what you're saying is go into those different environments, because now we were treating players, but it was an open room and there was 4 physios treating, and it was heaven to me, because I could see how we all were doing things different, we were talking, and you learn so much from that. And if you can't get that and you're just in a clinic, courses, doing courses is massive, because not only are you listening to the people taking the course, but then you're practicing on each other and you're getting that feedback. So I agree with you. Like, I think the physios that do really, really well are the ones that feel like it's lifelong learning. You're continually wanting to update yourself and go.
And two things to that is, remember, one thing would be shadowing. So if you can't do it just at course, you can still go on, if you've got a day off on a Thursday, go and sit in with someone and those sort of things. With my master's, I did over 250 hours. I just remember that from there, but I did way more than that going through med school. 250 hours of just shadowing clinics of physio, exercise physios, podiatrists, all this sort of stuff to learn. And then my other point is, don't measure yourself about those successful physios or those successful doctors or those that are either in the media or those that you see go to conferences. To be some of the most successful physios I know are just ones that are so good in their clinic. And in my head, they're successful because they're bloody impactful and they're really good. They don't do research, they don't present, but what they are the best at, and I love using them. And they're really hard to get into because they are so good. People know they're good, but you might not know who they are, but that's still successful. Because I think everyone thinks they need, and I used to be this, I think I needed to be, in my world, it was the Kareem Khan, the Peter Brewer, all those sort of things, right? And it's now I don't want to be that necessarily. I just want to be better than everyone else. But no, I just want to be good at what I do and balance my roles of family and things like that. So, yeah.
And you're very good at what you do.
We'll see.
We're very lucky to have you on. I reckon we're near the end. I hope everyone's taking some notes here. There's been so many pearls of wisdom in there, and I've taken a lot of notes, so I hope you have. But if you haven't, and you're going to sort of reflect on some of the most important points, you can look at the show notes. We'll put Tame the Beast, the persistent pain website, in there. So you touched on that. It's a freely available education tool and videos. Led by or created by David Moen and Professor Lorimer Mosley. and professional communicator Sam Chisholm. I'm just going off their website, tamethebeast.org. We'll put that in the show notes. You also mentioned the screen them criteria for the acronym for identifying conditions that might be rheumatologically related or monoarthropathies. I don't know if it was created by Paul Kerwin or whether the infographic is, but shout out to Paul Kerwin. I'll put that from the knee resource into the show notes. A really good infographic I've found while you've been talking. And just encourage everybody just to reflect on this really interesting conversation with Liam, because he's given us some really he's gone beyond what I thought you would give us. I mean, maybe think back to the beginning of the conversation. What did you think a sports doctor did, and how did you think that you might work with one in your career? And then reflect on just the breadth of the work that you do. And that should be some inspiration for health professionals at all levels and all types. So any final thoughts from you both?
Yeah, we don't just wear a pink vest on the side of an AFL oval, although we sometimes look good in them. No, look, I want to thank you both. I was very sincere at the beginning where I said I did feel like I probably would have really enjoyed being a physio, and I still do. And I learned a lot from physios. And that, I hope it's the other way around. I hope I have the ability to teach physio some things that help them. I'm not asking them to be surrogate doctors. But I think where you'll find most enjoyment is where you actually work closely with people of different disciplines. That's what I find. So my footy club and both the clinics I work at have people from different disciplines, and I gravitate towards those. And so I think put yourself out there and do those things, and I think you'll go really well. And my only other thing, knowing that your students and beginning your career listening, is don't try and rush to get somewhere. Please enjoy the journey, because we've all three of us that are talking about that have always thought about, like, I need to do this, but you forget about actually it's meant to be fun. And you end up trying to network with all these people 25 years older than you. You forget to network with people in your year group who are going to be your colleagues for the next 30 years. So don't always try and lift up and close the door on people next to you, because you'll end up isolating yourself. And so, think about the short, medium and long-term components of what your goals are, and don't rush. It will, if you are actually good and you put yourself out there, it'll come to you quicker than obviously the outside world thinks you deserve it. You'll think it's not quick enough, but it's probably right at the right time, and just enjoy it. That's enough for me, for hours of me.
It's really good. That's that consistent effort, isn't it?
Yeah.
Well, where can listeners track you down? They obviously make an appointment if you're local. but so you're Alphington Sports Medicine, which is a really good clinic, really well established, really well renowned clinic in Melbourne. Also, so you're on the social media stuff these days. Do you have an at?
If they want to see my kids, that's pretty much all I put up there. I would say, what is it now? X, Twitter. I actually don't even know what it is anymore.
That's okay. You can find it pretty easily on Google.
I'll tell you what we'll do. We'll put it in the show notes and do it from that point of view. But,
sure.
I do a bit of social media, a bit of Twitter, but not a huge amount. I would say. And if you're
playing it down, you've hosted the BJSM, or British Journal of Sports Medicine podcast, and written blogs. I've been involved in a lot of professional development activities.
Actually,
any courses and other things you want to promote?
Yeah, I will promote. I wrote the last, in the Brooklyn and Karen book, I wrote the last chapter, and then I wrote it again this year with some excellent colleagues. I was very keen to have some female input, some great Kim Harmon and Alicia Tang, who was originally from Australia, help in that, which is about working in team sports, but realistically, it's got a lot about how to develop a career. And there's other chapters to that, but I think if you read that in the new book in Calm, which probably when you're listening to this and it gets edited, it will be out now to buy. I do think that book, as well as being the Bible for where you want to begin for any injury, is actually now set up pretty well to give you some tips on things about how you interact with people on social media, in terms of should you, with your athletes, be taking photos with them, should you not, where your professional boundaries. And ironically, it's a lot of stuff you don't learn in a book, but it's in a book, is how I tell people. And so I would like to plug that, because I wish a lot of the stuff that's in there, and that's synthesized, if you think about the three people that wrote that career, there's It's like, she worked for 35, so it's going to be well over 50 years, probably over 70 years of clinical sports med experience, and we've obviously spoken to a lot of people, so that's underplaying it. And it's synthesized into what we think is a pretty cool chapter, and some of my friends have wrote other chapters in that book around this. And I think if someone had given me that at the beginning of my journey and had that vicarious learning, it would have been bloody useful. And so, yeah, that would be my only plug. Otherwise, yeah, they can Google me and see if they're bored.
And students, you have to go deep. You have to put the effort in. You heard about Liam going on buses throughout the night to meet a person for half an hour at a conference, and then coming back and at 2 a.m. and then working as a doctor all the next day. I mean, maybe not that extreme, but you have to get in. You have to read books. The Brook Doing Khan textbook we used to use so much, we got told to stop using it and maybe read more broadly. And there's a bit of a trend for that to be just not looked at. I don't know, everyone's different, but that's a really good resource. When we first started working as physios, that book was the Red Book, the very first edition, and it had just been written, and it was so useful because Karim Khan and Peter Bruckner had sat down and put their clinical experience into a textbook, and there was no internet. You can't imagine it, you young people. You can't imagine it. Here I go. It's just so important. So just be really aware of the quality resources you've got. Don't get off my soapbox.
Well,
so Bruckner and Khan. We've got two chapter authors here. Both you and Zuzana have written a chapter in that book. Yeah, so
correct.
Really good resource. Any final thoughts or no?
I was just going to say, as a physio, if you have the opportunity to work with sports medicine practitioners, even like you said, just shadowing, you can ask clinics and all of that sort of stuff. Get in touch. I think it really does open your eyes. As a physio, I work in a sports medicine clinic with a lot of doctors, and what I find really helps me is, yes, I do the physio part, but what I really like is the stuff that we don't do, which is what you guys do, is, do a lot of tests. So whether it's blood test, other investigations, and it actually then helps reinforce what my learning in clinical reasoning. And I'm like, oh, okay, I was on the right track because this is what I was thinking. Or the other thing is, wow, I didn't even think of that. And there's all these other medical things that can come into play, which you just think, wow. And it can, like you're saying, it can really help you learn, and it makes you a better practitioner. And the more you can learn, the more you'll pick up things that you hadn't before on your future patients.
Yeah, really well said. Thanks to you both very much for the episode. I'm going to be listening to it again. I learned a lot from that. So we're all very lucky to have you, Liam, and sharing some of your experience and wisdom with us on the podcast. So thanks again.
Thank you very much for having me.
So thanks for joining us, everyone, in this conversation. Do share, and if you found this episode interesting, share it with someone else who will find it useful as well. And you can always tag us in, Zuzana and I, at Periton Physio on the social media stuff, or at Luke Periton, or at Dr. Zuzi. She's now a PhD, so she can actually use her at. So do that. And if you have any questions or anything else, other topics you want to cover on the podcast, you know where to find me. So track me down and let me know. And until next time, this is Liam, Zuzana, and Luke wishing you all the best with your studying, professional development, and lifelong learning.